You're listening to the podcast between doctors and friends.
Pain. This is our topic this episode. Managing pain, whether you're working out, you got hurt, or you're recovering from surgery. Dr. Foz, Dr. Ray, what do you have to say about pain, and what would you like listeners to know about pain, or maybe your friends to know about pain, managing pain?
That's a very broad topic, so it's difficult to answer. Pain control in medicine has been very controversial topic. So there are a lot of different aspects to it. A lot of stuff, comes out in the news and social media regarding what to do, for pain in patients, but it's a very broad topic. So
Very complicated, and
yeah,
it's like saying, I mean, it's just it could be you're referring to acute pain, you could be referring to chronic pain. Those are handled very differently.
yeah. So historically, patients were given medications whenever they needed it for the pain management. And I think maybe in the early 2000s, Dr. Foz, you can correct the dates, maybe late 90s, the impression that patients were not getting enough pain control sort of came to the forefront, and they added pain as a vital sign, the so-called fifth vital sign, so that when nurses talked to the patients and took their blood pressure, their pulse, respiratory rate, temperature, they would also ask them where their pain scale was. And we never, at that point, they decided that we didn't want patients to be in pain ever, so they started giving them narcotics willy-nilly. Oh, you stubbed your toe, here's 50 Vicodin. Oh, you
Wow.
have a cough and you bruised your lung, here's 30 Vicodin, or whatever it might be. And because we didn't want people to be in pain, we didn't want them complaining that they were in pain, we didn't want them saying that they were in pain. So patients who came to the hospital for whatever reason were given a lot of pain medications. And this was also fueled by the pharmaceutical drug company, especially Purdue Pharma. And there are many, many documentaries about that. And the movie with Michael Keaton, I forget which that movie is an excellent movie that everyone should watch. They pushed the narcotics on doctors too, and told us, don't let your patients be in pain. We don't let anyone be in pain. That's a terrible thing to have. We don't want any pain. So every patient was getting narcotics left and right because we wanted them to be comfortable. And so people having surgery went home on, large amounts of narcotics because we thought that their pain was intolerable and they needed all this medication. And subsequently, everyone became addicted to narcotics, and that turned the whole pendulum the other way. And now we have an incredible opiate addiction problem in this country, very likely fueled by this pharmaceutical, you know, it, interventions that doctors did, thinking that we were doing the right thing, influenced by, a pharma company. And then we kind of went the other way, where it was like, okay, you get no pain medicine. Oh, you broke your arm, take some Motrin. You don't need any pain medicine because we don't want you to get addicted. So we swung the whole other way, where we stopped giving all sorts of narcotics to everybody. So it's a matter of finding that right balance of what the patient actually needs and what the patient actually requires for the situation that they're in. Because a lot of people, never had a drug addiction, never had drug history, had some sort of, maybe they fell and they broke their ankle and they went home with 50, 60 Vicodins, and they took a few because they were having some pain in the beginning. And whatever triggered in their brain, like, oh, this kind of feels good, and I'm going to take a couple more Vicodins, and now I need more Vicodins, and I'm going to go back to the doctor and say, my ankle's still hurting, I need more Vicodin. The doctor is going to say, sure, here's 100 more Vicodin, go have them. And now we've created, an addict. And there's been many, many stories of people who were perfectly normal, had a medical incident, and became addicted to painkillers. So
Yeah,
we have to find
yeah,
that balance.
that's where I agree with you. I think one of the most important things before we get further into the topic is this is an extraordinarily complicated topic that really has to be guided by an individual's circumstances.
Yeah.
So, that's one thing to really know. There isn't like blanket statements for all of
Well,
this. And then I
well,
do want to comment on, the whole Purdue Pharmacy and we as doctors are influenced. I think that's a little bit of a misperception of of I like Dr. Ray and I understand, but I just want to make sure that the public or the people who are listening to it's like we're not easily swayed. Like I don't get paid out by any insurance company or pharmaceutical company, I should say. Like it's the influence isn't necessarily direct. It's not like people are like scheming to like, okay, let's, we're going to go visit Dr. Foz's office and we're going to tell her this and that and the other. And all of a sudden I'm coming out prescribing X, Y, and Z. Like it's not quite like that. It's really more indirect. And it's kind of like this, what I always worry about is selective research, because for a medication to like come to market, they have to prove efficacy, they have to prove safety. This is done through, years of trials on non-humans and then to humans. And um, you have to, I understand that you have to publicize what needs to happen. What I'm worried about is when you redact information that shows that it's not as helpful, and then you only publish the positive things, And so there's stuff like that. But I mean, we're influenced, but we're not directly influenced because there's a lot of patients who think we're in collusion with pharmaceutical companies. We are all just as skeptical of them as I think the general public may be, and um, it's just that medications take so long and it costs so much money to go through R&D and to make it to market. And so there's a lot of steps along the way. And, we're not at their beck and call, or we want what's best for our patients. I don't do what's best for somebody's docs.
why don't
Right.
we take a step back as your friend? Like, what kind of over-the-counter pain medication should a household like my house should have? Is it Tylenol, Aleve?
Well, see, that's where it gets really dicey, right?
Ah,
And so
okay.
so like there's certain things. So like Tylenol in general, as long as it's not exceeded, so acetaminophen, right, is the
Uh-huh.
active ingredient. It's paracetamol overseas. It's one of the few medications that often has different generic names for the same molecule depending on which country of origin it is. So we're using Tylenol as the manufacturer, that's the trademark name. But acetaminophen, as long as you don't exceed recommended doses, we don't think that there's a lot of serious long-term consequences for it. Though I did read a study once that if you exceeded X dose, that it may be associated with some kidney damage in the future. That's never come to prominence in anything else. So that I don't want people to now be terrified of their Tylenol. It is not a hugely potent pain medication. Some people have good results with it, some things, some people don't. It is easy on the stomach. It's not associated with really anything else serious as long as you don't exceed recommended doses. In excessive doses, it's absolutely dangerous, just like anything else. I mean, you could say that even too for like salt, right? You put a little salt on your food, probably won't die today. If you eat a whole box of salt today, you might get really sick. So you kind of have to qualify it with that. So, but it is helpful for fever reduction, and that's a whole other complicated discussion to itself. Like, what's the origin of the fever? Should be reducing that fever, But that's something to think about having handy.
So it's
I,
safe to have Tylenol in the medicine cabinet.
yeah, I
Well,
would.
Or no,
yeah.
acetaminophen.
Well, my caution once again is what happens is people get a cold and they get a fever. So they've taken like a multi-cold symptom medication that has acetaminophen in it and they don't know that. Now they also take a couple of Tylenol and they think, well, an extra one won't hurt because I feel like garbage. And then pretty soon your Tylenol toxic. Or there's some prescription pain medications that are in combination with acetaminophen. So as long as you are knowing what your doses are and what you're doing, then it's not a big deal.
So what's a safe dose? Like,
I
I,
would read
wo-
the
I work.
box. I would follow the instructions on the box. I always keep Tylenol, and I always keep an acetaminophen product and a ibuprofen product in my house. And when my 3 kids went off to college, I put that in their little medicine kit that I made them, because Tylenol is good for, headaches, fever reduction. Ibuprofen is more of a, anti-inflammatory, helps with menstrual cramps, or if they, you know, twisted their ankle playing soccer or something like that. So they have different uses, but I think both of them are good to keep in the house for just, the first
Well,
line pain control.
speaking directly to our host and our host family, I agree. I mean, NSAIDs like ibuprofen, which is sold under Motrin and Advil and other names, naproxen, which is under Aleve as well as other names, are over the counter now. They didn't used to be years and years ago. They are over the counter, but they are not safe. NSAIDs are not safe for everybody, and that's what I think people need to understand. I'm not a huge fan of NSAIDs for people over the age of about
Wait, wait,
60.
wait.
My
You said what's the word? And said?
NSAIDs, non-steroidal anti-inflammatory drugs.
Okay.
So ibuprofen, which is Advil Motrin, or naproxen, which is Aleve. Those are the most commonly available. There are other ones that are prescription only, but they are associated with long-term adverse events. Like it's not really recommended for long-term use in older populations or in patients with certain medical conditions.
Wow.
So it's not as benign. And so referring to some of your family members who I know are suffering from chronic pain, I'm sure NSAIDs would help that individual. However, I would not recommend it.
Wow. Wow. We have
I would absolutely not recommend it. It's not safe for that person's medical history.
wow.
I see somebody has their hand up.
Yeah. Nish. Welcome, Nish. Hard question.
Well, we can't give specific medical advice, right?
Yeah.
So I think that's kind of what you're asking, and I'm not able to really comment on that. Postoperative pain is different than chronic pain, which is different than cancer pain. And so there's like a whole bunch of different kinds of pains, and so that's really
Oh
difficult.
wow.
Celebrex is a sister drug to the classic NSAIDs. That's a whole complicated discussion unto itself. I can't really comment on who, what, where, why. You would have to bring that up with your doctors. I also think that what I do hear from your statement is one of the things that I think people kind of lose, and it frustrates me a lot in primary care, is when they're only worried about the side effect and they're not worried what I'm trying to achieve. So I'm just going to use like a typical example of hypertension. So um, there was a study there was it was like a public health statement that was released like sometime during the pandemic. I have the original document somewhere. I just don't remember which drive I saved it on. And it basically said this. I'm just going to give you an example about in the United States, we are terrible at controlling hypertension, right? So just elevated blood pressure, high blood pressure. And we're terrible at it. We're not good at it. We're terrible. And if we could control the blood pressure of 80% of the people that need it, 80% of the time, we could save 6 million lives per year. That's nuts. That's a huge amount of people, right? And so, but it's a difficult discussion because somebody comes in for a rash, or I've got a problem with my hair or something, and you check their blood pressure, it's a little high, and you're like, hey, we need to monitor this, or hey, it's been persistently high. We need to think about treating this, and right away, oh no, I don't want to be addicted to meds, and I'm afraid of side effects. And I'm just kind of like, nobody is trying to give you medicine to make you feel like garbage. Nobody wants that, and we have lots of stuff that we could work around if it doesn't work out for somebody. And then the ultimate thing is we're sort of throwing the baby out with the bathwater. It's like we're not looking at the ultimate picture, which is somebody's life. And so just generally on Ozempic, there are potential side effects for it, but a lot of people do tolerate it well. And it also has indications to reduce the risk of heart disease and strokes in patients who are type 2 diabetics. So that's a really great indication. So if it were me, I would think about maybe trying that medication if I was a candidate or it was recommended to me, because I may have other benefits. And I think that's what I think sometimes gets lost in translation.
That's
Well,
a
thank you for that um, answer. I'd appreciate it. Although the on the Ozempic subject, I have a registered nurse coming to visit me because of this leg wound I have right now. And when I told her about what the doctor said I should be taking Ozempic, and she goes, "Well, yes, you have type 2 diabetes. You are controlling it very well with metformin, and you are not extremely overweight. You could lose a few pounds for sure, but you're not in the realm of people who should be prescribed Ozempic to control their type 2 diabetes, and not
Okay.
for weight loss,
Okay.
but for to control type 2 diabetes.
Once
She's
again,
you're
once
I
once
am not
again,
a I'm not a candidate for that. So she says that's
once
fine.
again, a few comments is this is asking for specific medical advice, and I don't know you. I don't know your history. You're not my
Right.
patient.
And
It
I'm
would be
not
unethical.
asking you for
Right.
that. I'm just like telling you
Two
I'm
comments.
just
Two
tell
comments on that.
I'm
Right.
making a comment,
You're,
and on what has occurred to me. You don't have to answer the comment. You could just say, oh, "Okay." Anyway, but um
I would urge you to think about two things about that. Is the same
okay.
thing with indications, right? So indications are not just for glucose control, they're for secondary events. So if I have somebody who has well-controlled diabetes, but they have had coronary issues or cardiac or kidney issues, I want them on Ozempic. I'll dial down something else and put them on that because there's benefit to it. And then I'm going to
Right.
say it. This is not going to be popular, but I'll say it. That's a nurse. That's not a doctor.
True. And my own primary doctor, because it was the surgeon for my leg that's telling me to take Ozempic. My primary doctor does not recommend that I take anything stronger than the metformin that I take for type 2 diabetes because I'm controlling it well with that drug. However, he wants me to get to the point where I don't have to take metformin. So we're not going to go up, we're going to go down, right? So he is encouraging me for more physical activity and things like that because that has helped me get my health in a better position. And I trust the advice of my primary doctor because he gives me tests all the time. He's watching my blood pressure, et cetera, et cetera. And also I just wanted to add he is very encouraging to me as other people and even the nurse because I was just so frustrated with all this pain I was experienced because of the side effects from that um, antibiotic. It was Bactrim, a sulfur based antibiotic. I've resorted to acupuncture, and acupuncture is helping me. I mean, my side effects have lessened much faster after I took acupuncture. So I do feel that people, if they are not getting, the results that they want through drugs, maybe you try something more holistic. I'm not a doctor, and you are not going to recommend things to people because you don't know me, but I'm just saying, as someone who has experienced very extreme, constant pain, that acupuncture can be helpful. That's it.
100%. I'm very pro acupuncture, so I'm glad that's been something that's helped you. That's great. And this is a very clear example of where pain management is such a complicated thing because it has to be so individualized. There's contraindications to things. There's long-term implications of things. Um, monitoring and change of events and have, there's often a discussion of like the root cause analysis, right? Like what has caused this. And if that can be addressed, that would be great. Sometimes it can't be addressed. And once again, this just alludes to the fact that it's a very in-depth, complicated discussion.
Yeah, and that could be confusing when you have your surgeon saying one thing. I would say, and I'm not a doctor. Stick with your what your primary care tells you. Primary doctor tells you. What are your thoughts on that, Dr. Foss, Dr. Ray?
Well, definitely, I think listen to the primary care physician. They know more of your medical history and your medical background. So, and they are the ones who are going to be treating you long after the surgeon is done.
And it's often also a discussion of why. Like, we're recommending this. So, like, just like I was saying in a theoretical example of a patient with relatively well controlled type 2 diabetes that has a significant heart history, they're fine. Everything's fine. We're doing great. I still think you should be on certain medications. And we're not talking just Ozempic, there's other agents that should be involved because they've been shown to reduce the risk of cardiovascular disease in a patient that's already really high risk. And so that's why, right? And it always comes down to if you don't want to do it, that's your business, right? I've told you why and what the plan is and what you should expect from it. And that a lot of these things are not necessarily life changing in a negative way. You can roll things back or discontinue things if they don't work out. That happens, and that's perfectly fine. And it's frustrating for patients who do want certain therapies that don't work, and you're like, well, you didn't tolerate it, and we just have to accept that now, and that's just okay. But I think that's the important discussion: is what's the plan, why, what are we getting, and revisiting issues like let touch bases, like is it getting better, is it getting worse, are we talking?
Exactly. No, I amen to that. Because yes, I really trust my primary care doctor. I mean, he was when I told him. I also talked to him after I experienced started having these side effects, and then he even said like, "Oh no, you should have stopped taking that antibiotic right away." But I said the surgeon said I had to finish it because otherwise I could get an infection in this wound. It's like, but he could have given you something else. I mean, but you know what? It's like two doctors' opinions that are different, and I'm being treated by the surgeon for this wound, so I just did what he told me to do, right? And then it's like I really get messed up outside of this wound. The wound is fine. I mean, this thing is not going to close up. It's been here for a month, and it is not infected, and the nurse comes to examine it every week, and she goes, "You're doing a good job." So it's cool, like I'm taking care of it. But my primary care doctor knows me, and it's like, he wouldn't ever prescribe something like that. I don't know. Anyway, but
Well,
I
the hard
trust
part about this,
my.
it sounds like, is you were being diligent about following your doctor's orders. My surgeon said I had to take this and I had to finish it. Like, you were being a diligent patient that we want. It's just unfortunate that it was also a situation that emerged that it didn't quite work out. And if there was some other intervention earlier, like, oh, maybe you should stop this. But patients don't know that, and that's what I always tell
We
my
don't
patients. It's
know.
like, well,
Yeah, we
yeah, it's
don't
Okay,
like
know.
if I
I
could
have a
stand
question
next to
here.
you 24/7, then it would be fine, but it's not, can't
So I
work,
have a question. Is there any possibilities now? I know, in many past episodes we talk about time. Is there any possibility where you could say, "Hey, surgeon, can you talk to my primary care?" Or primary care, can you talk to my surgeon? Does that ever happen?
Absolutely.
Oh,
Well, it depends on the organizations and how it works in your situation. So there's a lot of larger healthcare organizations where everybody's on the same EHR and you can see everything that happens, and so it's a
mm,
little less, and you can message each other as providers like, hey, so and so's, having issues with this. I told them to follow up with you, or I ordered this and sent them back to you, or or something like that. And then other places, it's like a phone call or even a text message like, hey, call me about a
uh-huh.
mutual patient. So we do try to talk to each other 100%. I love to talk to my specialist. Love it.
Wow, that's good to know. Okay.
Well, I'm glad you love it. Apparently, my surgeon doesn't, but that's just how he is, okay? If there's a more important surgery going on, he cancels mine. You know, that's what happens. But you know what? Hopefully, my scheduled surgery will be done this time.
Okay.
So that's all I'm hoping for. And in the meantime, I am lessening my pain and suffering from side effects through acupuncture. That
So
is
Great.
helping me best.
we have a surgeon here. Um, Dr. Ray, why do surgeons sometimes have to cancel, last minute because of an earlier surgery?
Oh, there's so many reasons that patients get rescheduled.
Emergency.
Yeah,
Emergency.
they're usually emergencies. So, um, a general surgeon is somebody who does gallbladder removals, appendix, colon surgeries. If they have scheduled, gallbladder surgeries the next day, 3 of them, and they're people who have dealt with gallstones for a couple of months and they're just going to show up and they're perfectly stable condition, maybe that morning they get an emergency consult in the emergency room that there's a patient with acute gallstones, that one of the stones is stuck in what we call the common bile duct, and they're having major complications and problems, and they're deteriorating rather quickly, and they need to have their surgery done urgently. So the person who is stable and has had chronic gallstones versus this acute person in the emergency room, that person has to go first. Oftentimes, they're able to fit them in between patients, or the surgeon just works a longer day to get them done. But sometimes they might be limited on their resources and they have to cancel a patient. And it's unfortunate, and we don't like doing it, but sometimes we need to do that. There are limited healthcare resources, limited operating room time, staffing shortages, a whole variety of things that go into this. But the doctors don't want to cancel you. It messes up their schedule. It messes up their livelihood. So we don't want to do that, but sometimes we have to do that because we have urgencies going on. As an obstetrician gynecologist, I deliver babies, and I have babies delivering at all times of the day. And sometimes I'm in my office and they call me to go do a delivery, and that delivery, instead of being a 30-minute simple delivery, turns into a 2 or 3 hour emergent, situation, and I have to cancel my office, and maybe those patients get upset because they'd been waiting for that appointment for weeks and weeks, and now it had to be canceled. But I can't be in 2 places at one time, so unfortunately, the more stable person has to bear the brunt of the cancellation. The general surgeons, the trauma surgeons, the orthopedic surgeons, the ENTs, the ophthalmologists, everyone has their own emergency in their field, and if they can schedule everyone and the schedule works out perfect, then everyone's happy. But when those emergencies come in, they have to be taken care of. And there's only so many resources, so many doctors, so many nurses. So sometimes somebody draws the short straw.
Yeah, I totally get it. Mine wasn't an emergency, and the lady at my surgeon's office said, unfortunately, the surgery that my surgeon was on was an emergency surgery, although he was on call. And I was thinking, why are you on call on the day that I'm having my surgery? But anyway, um, he he realized that what he's doing is going to take a long time, so he will
Yeah.
probably miss my surgery. So that's why she said that he had to do it. Now she knew, because I could tell in her voice. I didn't want to hear these words, because she's the one that answers the phone when I'm saying, my entire body feels like it's on fire. He must do something for me now, okay? So
Yeah.
she knows I've been suffering. So she
Well,
said
he's
she
not,
got
he's,
me the soonest appointment that they could find for me at the same surgery center, which is,
Yeah.
next week.
He's not
Yeah,
making that decision lightly. He's involved in a very complicated case, and that
yeah.
his mind and his talents are needed to help that patient in their complication that's going on. So
Mm,
rather than be distracted during that surgery thinking, oh, I've got another patient, I've got to deal with that other patient, what am I going to do? I'm running late. He made a very good decision to just, cancel a stable patient and reschedule them so he can focus on what's happening and what's going on with his current complicated surgery, so he can provide the
mhm,
best care to that patient, and hopefully that patient, survived and had a good outcome.
mhm. Well, yeah, I certainly hope so because was sacrificed for that person, so I hope that they are um, mending and they're going to have a beautiful life. And I hope the same for myself. When it's time for my surgery, I have 100% of that man's attention on
Good.
this leg, getting this thing out of my leg so I can live a prosperous life after this. And I'm sure he will do it because he is an expert in his field. His name is Dr. Marcus, and he teaches different. He has modern methods of surgery with robotic things or whatever it is. Anyway, he teaches that, so he's a specialist in his field. So hopefully, but if he's using robots on the leg, good. Then just use those robots to get all this stuff out. I don't care. Just want it out. But yes, I
Well,
understand.
as I've learned in this podcast, the various episodes we've had, get an early morning appointment.
Totally.
Yeah.
Always
Yeah.
early in the morning.
I know.
First
Unfortunately,
appointment of the day.
mine is for the afternoon. So fingers crossed, it's gonna happen. It just has to happen. Saying, Lord, this must happen now. This thing has to come out. Okay. So uh, my doctor will be able to come do this for me on the afternoon of December 15th, and it's gonna work out good. It's gonna
So
work out great.
back to the pain, right? So after someone has a surgery, um, I noticed from my experience, I get the acetaminophen and I get the stronger drugs and all that. Um, I try not to take the stronger, the prescription drugs unless I really need to. Um, what do you, I feel like, and correct me if I'm wrong, I feel like if I take these stronger medications, then, I just get constipated and then those are side effects. What are
Right.
your thoughts? Uh-huh.
Right. Well, definitely, constipation is a side effect of opioids. So, limiting the use will limit that side effect of constipation. But, like I was talking about earlier, so, medicine first gave patients all the pain medicine they needed, and then we went back to you need zero pain medicine, and
Uh-huh.
then now we've tried to find that happy medium, and we started doing studies and talking to patients about what is it that they need for pain control, and everyone's pain tolerance is different and
Yeah.
everyone needs different medications. So for example, since I do obstetrics, we have patients delivering babies. So after they delivered babies. When I first started my career, we would send them home with some narcotic medications. We would send them home with some ibuprofen and thinking that, she just had a baby. She's going to obviously be in pain. This is something that we want to keep them comfortable with. But then as we listened to the patients and as time went on and more studies were done, realizing that most patients after a vaginal delivery need a couple of Motrin tablets, and that's maybe about it. Very few of them
Uh-huh.
were actually using their narcotics. Very few of them actually needed them. And a lot of patients, including myself after my deliveries, needed no pain medication at all. And it's it's something that
Wow.
we gave it to them automatically at some point until we sort of figured out that they actually don't really need or require a lot of pain medication. And same with the cesarean section patients. Cesarean section is a major operation, so we thought we'd load them up on pain medicine, and then realizing that a lot of these women were tolerating the pain fine with just maybe a couple of Motrin, and that's about it. So we started looking at what did they require while they were in the hospital, and they have usually a 3 or 4 day stay in the hospital. If by day 3 or 4 they're only using Motrin and they're not using any kind of narcotic pain medicines, then we're not sending them home with the narcotics. We're just sending them home with Motrin. Some people have maybe a lower pain tolerance and they're still requiring some of the narcotics, so we'll send them home with a few of the narcotics. But now realizing and prescribing just maybe 5 to 10 tablets of narcotics, whereas before we would easily give 30 to 50. So it really
Wow.
depends on everyone's pain tolerance and what they need. And I do a
Right.
lot of outpatient surgery procedures, and sometimes I send them home with maybe just 3 or 4 narcotics, and I would say 100% of my patients have never come back to complain that they were in so much pain and their pain medication did not alleviate
There's
it.
improvement too, right? In like over the years, as years have passed with like perioperative pain management. And so there's stuff that's done. And it's like a lot of surgeons, when there's an anticipated incision, they'll shoot that up with a lot of long acting local anesthetic,
Right.
like lidocaine. And so you're not going to have any wound pain at all for 8 hours after the fact. So
Right.
there's a lot of stuff that can be done, and that's safe and well tolerated. So there's a lot of tricks, but I think it's really, really, once again, because it's such a complicated issue, and this is something that has impacted primary care, in a huge way. There's acute pain, which would include a subcategory of perioperative pain, right? So, or surgical pain, and then there's chronic pain, and those are different. And I will also say respectfully, I'm going to guess, since I know that Dr. Ray's love is baby deliveries, most ladies who are having babies are young. They're usually younger. They might not necessarily be healthy. Unfortunately, not everybody's fortunate enough to enjoy good health even in their younger years, but they're generally younger. So certain things like cardiovascular disease and stroke risk are from, chronic atherosclerotic disease and all those things are not as common. So a lot of those patients don't have any pre-existing contraindications to things like Motrin and all that stuff. But that may not always be something that is a great choice for somebody who's, a 70-year-old having an aortic aneurysm repair
Mhm.
or, like a hip replacement or something. And I will say that also sometimes it's gone the other way. Like there's so much more regulation on us as physicians when it comes to narcotic pain medications. Like sometimes, depending on which state that you practice in, you have to run the patient's name through a prescription medication database and see what their pattern of narcotic use is before you can prescribe something. And so it varies very much by state. But the Department of Justice is involved in all these things. We're DEA license holders, right? So that's a big deal. But it's interesting too, because it can be the other way. I had a patient, this was many, many years ago, who was a person who had a bypass surgery. And I didn't even know this was going to happen. It was done on an urgent basis. And I get this phone call in the morning saying, oh, hey, so and so called. They just had bypass and are having a lot of pain. You need to do something. And I'm thinking, wait, what? And so I finally assessed the situation. And this was somebody who is a very atypical candidate for a bypass, had this huge chest incision done. They cut open this person's chest so they could save their life and, um, you know, ch- uh, redo her blood vessels and stitch her back together, and then forgot to send them home with pain medicines. Had no pain
Wow.
medicines except for Tylenol, and that is
Well,
chest
Wow.
procedures tend to be kind of uncomfortable because you have to breathe. Like every time you take a breath, you're stretching what was there. And so I saw this person. I was like, oh my God, what happened to you? And I gave them some appropriate narcotic pain medication after we determined that was the safest thing to do. And then I called the hospitalist and said, how did you send this person home without any pain medication? And it was this whole big complicated discussion, but basically it was an oversight. But I thought that was cruel. I thought that was cruel.
Yeah. But
Well,
you know what? I wanted, if you don't mind, go back to when you said like you have to look up a person's history. Like if I were prescribed strong narcotic pain medications in the past, there's a record of that so that any doctor could say, "Oh, this woman might be an addict or something. She just
Depends
has a
depends
lot
on the
of
Yeah.
state.
these."
Depends on the state that you're in. So every state has a different
oh,
situation. I have to emphasize that. And but generally, that is more standard. And I don't practice in all 50 states because I don't live in all 50 states. But generally, most states do have a prescription drug database monitoring program where anything that is considered a scheduled drug, so something that requires a DEA license to prescribe, so not just diabetes medicines or blood pressure medicines or things that are not over the counter. There's a difference. So there's scheduled drugs and then there's non-scheduled. We used to call those triplicates back in the day. And in a lot of places, you run a patient's name just to make sure there isn't signs of abuse. Because if somebody coming to me like, oh, I need 20 Norcos for my chronic knee pain or 30 Norcos, okay, here's your 30 Norcos. And the next day they go to Dr. So-and-so and Dr. O tell them the same story. And so we are responsible for looking for signs of overprescribing, as well as really it's more about diversion. It's not really about use. It's about diversion. So if I have somebody who's on like chronic opioid medications, right? So those are morphine derivatives. Those are all scheduled drugs that require DEA licensing to prescribe. And so if I have somebody who's on those, and they come to me and I'm supposed to make sure they're not diverting them, so I can say, hey, pee in a cup right now. I need to make sure you're not also using street drugs that would make me think there's something going on, or overusing it, or I need you to bring in all your pills so I can do a pill count to make sure that you're using exactly what should be and not overusing them. Or often it's really is, hi, Mr. So and so, you're on this for your chronic whatever, pee in a cup right now. If I don't detect the drug, then that's suspicious for diversion. So I don't know if you are getting the prescription from me, not using it, and just selling it on the side.
oh
So it's
wow.
that's yeah.
Oh.
So that's why there's a lot of stuff. And so when people, so I don't really like to do these because you know why? It's a headache. I don't have time for this. It's just like I have to worry about your pill counts and I have to worry about the last time you peed in a cup for me. And then there's the difficult conversation of, well, you're here for a refill, but we're not detecting the medication in your urine. Is that because you ran out? Or is that because you're diverting it? Or is that because you're hoarding it? Like patients will hoard pain medicines, not because they're doing anything nefarious, but they're so scared of being without pain medicines and having that pain. And they know that it's hard to get because they've been not denied before. And so it creates all these really difficult, complicated behaviors. And
Wow.
it's terrible. Like it's terrible on so many layers, and I have 15 minutes to figure out what that complicated situation is.
Wow. So, what comes to mind when you're talking about that is two things. If you've seen the PDD documentary on Netflix, um, they found they found prescription, and maybe Auntie can help me remember this correctly. I think it's pain medicate some narcotic under Frank Black. How does that work? How do you get around, getting prescription
Well,
out of a pseudonym?
here's the thing is like, and once again, this is from a non-surgeon's point of view, right? Though I've, participated in surgeries, so I have done surgical procedures on people. I'm not a surgeon. Um, if somebody comes to me in my office, like their generally identity is usually vetted because we've checked their insurance and their ID. So it's not like I don't know who you are, right?
Okay.
That would be kind of hard to like, we don't really see people who like, I can't really determine who you are. There are some places that I have worked in clinics where that does happen, and you have people who come in off the street and they also need help. So it's complicated on many levels.
Mm. Auntie, you have a comment, question?
I just wanted to just kind of clear it up a bit when it comes to the Frank Black. So what he did was highly illegal and should not be done by any means. It is very illegal to use someone else's name for a prescription, and which is why he had a very long trial. And it tied into organized crime and RICO. So no, he was not.
Yeah, like
Sean Combs.
Right,
He
you
was
can't. Right, you
medication.
can't prescribe medications under a pseudonym. So if I was working somewhere and a celebrity or a powerful politician or something comes in and says, "Hey, I need, Norcos,
Uh-huh.
but I don't want you to give it to me. Like, I want you to prescribe it under my assistant's name or something like that." Like, that's not legal. I can't do that, and I won't do that. And that's
Got
why
it.
I'm always like terrified. Like, I don't want anybody important to ever come see me. I don't want to deal with that headache because I can see where, you know, there's money and there's influence and there's power. And, even in some places where you can work, I don't work with people like that at all.
Uh-huh.
But there are certain influences that can happen to make you behave in ways that you would normally not do because
Uh-huh.
of whatever pressures there may be.
Yeah.
So I think it, and I think I just read something recently on Matthew Perry's death,
Yeah.
and
Yeah. I want
yeah,
to bring
that
that
whole
up.
thing, yeah, and it's just, ketamine is a controlled substance, and so, but once again, for the reasons I'm talking about, and there's surprisingly a lot of pill mills. Like, you'd be surprised at a lot of places that have a very low threshold for certain things. But there's death that's associated with that. I mean, that kills people. Like that, it is
Right.
scary.
So just like any occupation field will have corruption, there's corruption in medicine as well. And so there are some doctors willing to put their license on the line for money, for fame, for being celebrity adjacent,
Mhm.
for the
Michael Jackson.
right, for the ability
Classic
to
example.
say, I take care of this celebrity, I'm their personal doctor, to be put on, the Kardashians' Instagram, to get any of that level of fame and power and money. So those are the doctors who probably are going to be more susceptible to agreeing to give, a high power celebrity, what they want, because now you have sort of a in with them. If Tom Cruise walks into your office and says, "Hey, do me a big favor," it might be hard for a lot of doctors to resist that, because now maybe you can see the next Tom
Not
Cruise
me.
movie.
I'd be fine telling him no.
I like
We'll find
Dr. Fox.
somebody
I
else.
don't want it to be
Right.
I don't want any part of this. I would be the first one to be like, absolutely not. I'm so sorry. I'm not
Right.
the doctor for you.
Right. And then you have doctors like me and Dr. Foz who are like, we want to be anonymous. We don't want any power, money, fame. We don't want any recognition whatsoever. I just want to go to the grocery store in peace and not have anybody know who I am. So there are different personalities of different people in every walk of life. And so there are a lot of doctors who are very likely willing to bend rules and do what needs to be done. And like Dr. Foz mentioned, these pill mills, where basically patients come in and they say, "Oh, I have back pain," and the doctor writes them a prescription for 100 Vicodin. "Oh, you have back pain? Okay, here, 100 Vicodin, go." And it's all cash. Come in, pay $500 cash, get your prescription and go. And they come in once a
Wow.
month, and the doctor writes down chronic back pain, chronic migraines, chronic this, and gives them a prescription, and then they leave. And it's completely um unlawful, completely against every medical ethic, completely wrong in every sense of
Well,
everything.
it's against the science. If you
Right.
actually look at the medical literature on chronic pain, so we're talking chronic, once again, chronic, which means ongoing for periods of time. This is not,
Mhm.
something, we're not talking about cancer pain. Cancer's different. So that's the other thing too, is like pain associated with cancer. I'm all pro opioid, is whatever they need, right? Because this person is in the fight of their life and they're miserable and they need to be managed appropriately. That is not associated with negative outcomes, right? And we're not talking about other stuff like euthanasia. No, 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 no. We're just talking about pain management related to cancer. But there is no medical literature research support for chronic opioid use in chronic non-cancerous pain beyond 90 days of duration. There's no evidence that it's helpful
Right.
at all. So
Right.
we shouldn't be doing it. So if
Right.
somebody comes in and say, "Well, I've been having knee pain and and this and that, and I'd be on Vicodins or Norcos or Percocets for years," and okay, that's not indicated. Like, And now I will say this is there are times when exceptions should and need to be made. Those are different and it depends on everybody's individual circumstances. But there's other stuff. That doesn't mean that we don't want to manage your pain. That's
Mhm.
not what it's about. But it's like you need to find something that's more effective and helpful for the long term. And that's kind of what it comes down to is like the efficacy. You can use
Mhm.
it, but is it really giving you better functional scores, better pain control scores as time goes on?
So
Right.
And that's what the
taking
focus is.
acetaminophen for over 3 months every day is bad.
Right.
Probably not a big deal,
Yeah.
but probably not.
So basically, you have to figure out the source of the pain, and that's you need an
If you can.
evaluation by your doctor and figure out what the source of the pain is. Sometimes it's diagnosable. Maybe it's an ovarian cyst, maybe it's arthritis, maybe it's, degenerative back disease. So you can figure out what the source of the pain is first. So you need an evaluation. If you
Mhm.
can't figure out the source of the pain and you've exhausted everything and maybe you've seen multiple specialists and you don't have a source of the pain and you have a chronic pain syndrome, a chronic pelvic pain syndrome, then a referral to pain management would be the next step. There is an entire field of medicine dedicated to helping control chronic pain in patients. And these are doctors who specialize in this. And whether they can give you direct injections into the pain site, whether they can do other medications or manipulations or anything else, that is their specialty. So if a family medicine doctor or a primary care physician has managed your pain and there's no source to it and there's no improvement, the next step would be to see a pain specialist.
Mhm. Mhm. Um, I'm going to kind of lead us to a different direction, or maybe it's the same road, different direction. What about those like those lidocaine patches that you could buy over the counter for your
Harmless, harmless, surprised as long as you follow directions, right?
uh
Remember, anything can be used incorrectly. Anything could become toxic if you don't follow directions. But those types of things are not addictive and not a big deal. I'm a huge fan. If it works, I have found things like that to work in cases that I would not expect to work. But I don't worry about that for long-term things. It's like if the worst you're addicted to is having to put a lidocaine patch on your back a couple times a week,
Mhm.
ongoing, more power to you. I'm good. I'm good with that.
Now, you've told me once before that if you use it, follow the directions, don't go over the X amount of hours that the package tells you. Why?
Well, sometimes, so you don't want to do more than the X amount of patches because you absorb lidocaine through the skin. There is a systemic absorption, and that is a cardiovascular acting drug. So you can have toxic. Remember, we talked about toxicity. I know. See, now I've scared everybody who's going to want to go to their dentist. Remember, that's when you go to your dentist, you are under the care of a medical professional who knows what to do. Okay.
Mm.
So I'm always scared to say something because then everybody starts panicking. But there's a systemic absorption, and then you don't want to apply it over broken skin. So the skin should be intact and healthy, and you don't want to apply it underneath heat. So you don't want to put that on and then slap a heating pad over it because then that increases how much you absorb.
Wow, good to know that part.
So there's real like, that's why there's take this and not take that. Like there's a reason why we're telling you that.
Yeah, but
Those
you know what?
directions are not there for fun. They're there
My
for a
my
reason.
complaint is the directions are so small and I can't see it. And
Okay,
I
see
wonder
that
how
that's the kind of stuff that I'm like, all right, well then get better glasses.
get your
See,
phone,
there's a
zoom
solution, right?
in.
There's a solution to that. The fact that you don't want to pursue that solution is a you problem and not a me
It is. It is. Even the microwavable food, I'm just like, "Ah, no, just put it in 90 seconds. Who cares?"
problem.
Why are they making these instructions so small? So, well, that's pretty good. Anything else that we should conclude regarding pain? I mean, it's complicated. We could have another episode about this.
Well, sometimes there's a huge psychiatric component, and so I think that there's very much the mind-body connection, and I urge people who are suffering from chronic pain to pursue all avenues. Like
Uh-huh.
there's no, there's usually we can find something that works. It might take a long time. It might take a more complicated path. Unlike, maybe some of the patients where Dr. Ray is seeing, they deliver their babies, they take Motrin for a few days and then they're good, right? And remember, like I said, there isn't no role for acute pain treatment. Of course, we don't want people to suffer, but you just have to make sure that you're pursuing all avenues and kind of seeing the right specialists that you need to do if you need them. And second opinions are always a good thing.
Okay. So my takeaway right now, basic takeaway, good to have acetaminophen in your house, in your car.
Yeah,
But ibuprofen, again, depending on your health, for emergencies, like you just broke,
it's a more effective pain medication for certain types of pain. So,
okay.
and then it comes down to, there's a difference between prescription dosing, which Dr. Ray is probably giving her patients when they go home, versus over-the-counter dosing.
What? Okay. Auntie,
Yeah.
you got a question?
I do. Well, first of all, thank you both, Dr. Foz and Dr. Ray. I can listen to you both all day. But
Really? Really?
thank you for
No, I can't
Thanks,
do that.
Auntie.
I certainly had the misconception. I was one of the people that had the misconception that these pharmaceutical companies pay these doctors hand over fist, and they subscribe you things that you don't quote unquote need. And
I
I do.
wish they did in the past. I think because I came of age after all of those things. I think they used to do stuff like that, but yeah, that's not okay. Just so you know, it's absolutely not okay anymore.
Yeah.
Sorry, go ahead.
Well, in my 25 years of being a doctor, I've never earned one penny from a pharmaceutical company. So
Me neither.
they've come and brought lunch and they've given their spiel about their medication, and I'll listen to it, and whether or not I agree with it or want to give the medication is my decision and my decision only. But they definitely don't pay doctors, and there's a whole lot of misinformation, especially for the pediatricians with the vaccines, that they're getting some kind of kickback from the vaccine companies. I know 0 pediatricians who have ever
I
received
know.
1 penny from a vaccine company. So us doctors are not getting anything from pharmaceutical companies. Maybe
Yeah.
I'm getting some pens, maybe I'm getting some Olive Garden,
Are
but
they good
that
I
gel
don't even get
pens?
that.
but
You
that
know
is
what?
not
I don't even accept that, because I will take pens and samples to give to patients in the past, because
yeah.
that helps them. But I agree. We don't benefit from it at all. I actually do like talking to farm reps, because it gives me information on the cutting edge research. It's my responsibility to verify that, and to kind of decide if I like products or not. But I mean, a lot of stuff comes to market because it's helpful. Like we've had the discussions on, Ozempic and Mounjaro and all those things. So
Maybe
I
this
totally,
maybe
yeah.
pharmaceutical reps can be another topic, because there's a lot
Yeah.
to talk
Oh
about.
yeah, totally. But we cut off poor Auntie.
We did.
Okay, Auntie.
And you, believe it or not, you actually answered the other question I was going to have, because I was going to say, like, what do you have? Because the only reason that I even changed my tune when it came to that is because I just had a night. I personally didn't have a PCP being in between North Carolina and New York, but I still wanted to get my checkup, so I just went to the first thing that was available. And this really nice doctor, she was a young doctor, and she and I were just chit chatting, and she was the one who kind of woke it up for me. Is like, no, I'm not getting paid by this. No, this is not. I'm like, oh, you don't get paid? Oh, so I did my own research. So to the people who were like me and did not do the research, and they will maybe say things like, oh, I don't want to take medicine. Maybe I would want to drink some green tea. But you kind of answered it. You said these things don't come onto the market unless they're helpful. So I was going to ask, what would you
Well,
say to these people?
there are things that are introduced to market and then they are found to be not helpful and then are withdrawn from the market. And then there are some things you're like, oh, we saw too many negative things after much broader use. But if we're talking a lot of meds that have been on the market for 20 years plus, like one of the big things I always have is the discussions in primary care, diabetes, hypertension, and cholesterol with statins, right? The statin thing. Oh my God, if I had a nickel for every time I had to go over this stuff. But it's just like those meds most of them are pretty old. Like statins hit the market, like I don't know medicine without statins. I want to say it was the mid to late 90s. I don't know of a life. I would go, like, kind of wonder now, like, what did doctors do then? Like, what did we do? Like chanting and stuff? Like, I don't know what we did. So, but it's a lot of stuff, especially if it's an older drug, there is like no benefit. When I prescribe like atorvastatin, which is generic Lipitor, or rosuvastatin, which is generic Cristor, like nobody benefits from that. It's like $5 a month, whatever. There isn't any. There's no farm reps coming to talk to me about statins because there's still the name brands on the market, but there's
Wait, so
generic equivalents.
wait, to clarify, like no doctor benefits from it, right?
Well, you know what? I benefit
Patient.
from it because I know that your risk factors are where they should be. So
Okay,
yeah, I
okay.
benefit. But like I don't like if somebody's cholesterol isn't where it should be, it's because they're being stubborn and or not wanting to it, or it's not just the choice for them, which often conflicts with what medicine recommends.
Yeah.
Like nobody like I don't get a payout because somebody's cholesterol is good. Like I don't like nobody pats me on the back. Like I don't like get a promotion because of all that. Like it's I'm kind of like I'm kind of like an attorney if you can trust attorneys, so to speak. Like I am paid to be your advocate. That's like whether you take the treatment or not doesn't change what happens to me, if that makes any sense. Like
Mhm.
I get paid the same or I don't get paid. Like I don't get paid or whatever the situation is. Like it's just that it's my job to advocate for the patient, to tell them what is in their best interests. I don't have another horse in this race.
Mhm. Good info. And I think there's also that against the pharmaceutical, I think in the last decade or so. So, and Auntie's comment was to RFK Jr.
That's a whole nother podcast too.
That's another
Oh my
podcast.
gosh, yes.
All right. Well,
I'm so
let
sad over it. Oh wait, I have to say
oh
this.
yeah,
Did
yeah.
you know that this week that they rescinded the recommendations for infant hepatitis B vaccination as a standard vaccination?
Yes.
Wait, what does that
I
mean
think
in English?
so. Basically, routine childhood vaccinations include hepatitis B vaccination. It used to happen at within 24 hours of birth in low risk infants. It still does occur in higher risk infants, so their moms have problems.
Okay.
But it was pushed back to 2 months. So the schedule was initiated, at 2 months of age for any young child, a recommended routine vaccination, hepatitis B. Now they're saying, and that has reduced new neonatal, like I want to say the numbers are incredible. It's something like new neonatal infant infections with hepatitis B has fallen like into the double digits in the United States. Like it's something that rarely happens now. Almost every infant is fully protected from developing hepatitis B because of these vaccine, programs and recommendations. And I think that's awesome. Like anytime we can try to stamp any disease off the face of the earth, like we've done a great job. And then now that has been rescinded to become because of this new
Wow.
ACIP recommendations, right? Which is you can consider it, it's become optional. And the thing about that terrifies me is that means that there'll be some people who will opt out of it because they don't understand it or don't care to understand it. And then also the other thing that worries me is will it now not be covered by insurance? And so
Wow.
that would drive other people away from it because like, oh, I can't afford that. Like, and it's just, oh no, 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 no.
Wow. My dogs have more required vaccination.
Dr. Ray, how what are your thoughts on that? Does that scare you as much?
It does. I started reading about it and just got, very frustrated and upset. I haven't had a chance to speak to my pediatric colleagues, and I'm not sure what we're going to be doing at the hospital, whether we're going to be following that recommendation or not. So I think it's still a little bit new, and most people are shocked. But I think most pediatricians are just very disheartened. This decision has
No,
made a pediatrician's job that much harder
that
now.
much harder.
And we likely will see in the next coming 4 to 5 years, a rise in um, infant hepatitis and potentially leading to chronic liver disease in these babies that, could have been prevented just
I
because of,
know.
the ignorance of these people making medical decisions and having no medical training whatsoever. So
Well,
Um,
yeah, the thing with it is especially of all vaccines to pick on, like this one, really, like it's old. It's been on the market for 30 years. It's effective, especially in the young infant, and it's one when given as an adult. Like I almost have nobody complain about it. Like they don't go like, "Oh, my arm was hot and red and swollen, and I had a fever." Most people are like, "I was fine." So it's like a
Wow.
really well tolerated vaccine as well. It's like, oh, man, really?
yeah, I think it's. I think everybody this week was just sort of in shock and devastated, and maybe next week we'll start analyzing and deciding where we need to go with this information.
Wow.
Tragic.
Well, I guess we could end our podcast this
On
episode
that negative, sad note,
on that. Let's say something positive.
you could still get hepatitis B vaccinations, I'm sure, through some capacity. It doesn't mean that, and I encourage it strongly for all parents, all pregnant ladies, and people who are going to be having infants until there's other administration policy changes. Hepatitis B vaccination is not scary or dangerous. Hepatitis B virus is scary and dangerous.
Only 3 more years and 1 month. That's all I'll say.
All right, that concludes this episode.